Hello, everyone. Good evening. Today we have our virtual happy hour hosted by the Stroke ISIG, and we have Dr. Shannon Scott speaking to us about addressing return to work after stroke. Dr. Scott is an assistant professor at Ithaca College in New York. Her body of work has been in stroke, and she teaches a few courses in adult rehabilitation and also an advanced adult evidence-based practice in the Ithaca Center for Life Skills, which is sort of interesting component of her work. She's a graduate of the University of British Columbia in Vancouver and Quinnipiac University. And she's here to share with us her research on return to work. So thank you once again, Dr. Scott, for sharing your expertise with us. And hopefully we can have a lively discussion. So the floor is yours.
Great. Thanks, Cecile. So hello, everyone. I want to thank you for joining me. It is my pleasure today to be the presenter for the ACRM Stroke ISIG Virtual Happy Hour. As was mentioned, today I will be presenting and discussing my research that I completed for my OT doctoral capstone project that was also just recently published. So the title of my presentation is Addressing Return to Work After Stroke, the Practice Patterns of Occupational Therapy Practitioners and Implications for Interdisciplinary Practice. So first, I really want to thank members of the Stroke ISIG Executive Committee, especially Suzanne Burns, Communications Officer, and Jacqueline Schwartz, Secretary, who I believe may now be past Secretary. However, for their interest in my research and for inviting me to present today. I also really would like to thank Cecile Alpassan, who has been great and integral in assisting me with the technology and aspects of this presentation. So I just want to kind of give a frame of reference with regards to the research and the choice of topic for the research, and look at a study that was done by Wolfbaum and Connor in 2009. Essentially, within this, the researchers collected a database from 1999 to spring of 2008 of individuals who had sustained a stroke. And when we look at the statistics with regards to the number of individuals within this database that are under the age of 65, we see that 45% of stroke survivors in this database were of working age. And so this is important to note that that is a large percentage of stroke survivors whose life role is, in fact, working at that particular time. I also wanted to show this image, which I took from the National Stroke Association, because I think it's one thing to look at statistics with regards to the number of younger stroke survivors, but I think it's also really impactful to truly look at the face of individuals whose lives are impacted by stroke. Hopefully when we recognize that we are dealing with real life people whose lives have been disrupted and negatively impacted, that it will help facilitate a stronger sense of ethical and professional responsibility to us to provide services that truly move beyond traditional rehabilitation services and focus on participation and resumption of life roles. So looking at some of the problem worldwide, we do recognize that there is an increase in younger stroke survivors around the globe. And when we look at some of the research that has been done that looks at the return to work rates for these individuals, we see that on average, we're looking at approximately just over 50% of individuals who return to work after having sustained a stroke. Now, however, there's some variability in studies, so that you will, in times when reading research, see some range within this, but this is just a sampling of some of the more recent research from different countries around the world. So the question is, why is this a problem? And we recognize that the inability for younger stroke survivors to return to work is both a burden to society as well as the individual. On a societal level, we recognize that stroke is one of the #1 disabilities in the United States. And when we look at Social Security benefits that are paid in the U.S., 86% of those are related to disability. Additionally, lost productivity, i.e. the inability to return to work, is the largest contributor to the indirect costs associated with stroke. And it's relevant to note that these costs are expected to increase by 68% by 2030. On the individual basis, we can appreciate that the inability to return to work can lead to financial hardship, loss of personal identity, as well as structure to daily life, social isolation, impairment in social relationships and family relationships, and ultimately psychological and physical manifestations. When we look at the research that looks at the types of services that are provided to individuals of younger age, it's really seen as a confound in the sense that, like Wolfbaum and Connor found, that individuals that sustain a stroke at a younger age tend to have a less severe stroke, more of a mild stroke, and so often these individuals may receive little to no rehabilitation. Also, research has indicated that if services are received, and identified that age-related needs such as resumption of work is not addressed, and then looking at services such as vocational rehabilitation, that these services may not be specifically designed for the neurological population. So then when we look at research as far as the actual experiences of individuals who have sustained a stroke and have attempted to return to work, there is early motivation often associated with fear, with loss of employment and benefits. And so in some instances, this has a negative impact as individuals will resume work when not being necessarily ready to return to work. There's also research that does focus on that if the longer the time frame when individuals are not returning to work, that this early motivation wanes. And for those stroke survivors who do return to work, often they're unprepared. It requires multiple strategies and accommodations. They're not aware of resources, and they're not aware of the impact that stroke will have on their ability to resume work roles and responsibilities. And often persistent stroke-related impairments contribute to dissatisfaction with both performance and ability to perform, and ultimately 15% will leave within the first 6 months. So I really wanted to get an understanding of if occupational therapists were addressing return to work in their practice when working with younger stroke survivors. The work is within the domain of occupational therapy as far as our practice framework. Work is one of the 8 areas of occupation that occupational therapists focus on. And when looking at this image, you can see that while we are looking at occupations that individuals perform on a daily basis, we look at not only the individual themselves and their abilities and skills, but we also look at what are the tasks associated with that particular occupation, and then also what is the influence of context and environment on their ability to perform successfully. Additionally, the American Occupational Therapy Association has produced a statement in 2017 that outlines occupational therapy services in facilitating work participation and performance. And you can see that I think the understanding is often work is associated with work in industry, so individuals that have sustained injuries, typically musculoskeletal injuries on the job. However, as I said, the work is within the domain of occupational therapy in all disabilities, and that the AOTA identifies that we serve individuals that have not able to return to work because of disease, disability, or any injury. It's also important then, what I highlight is that occupational therapy practitioners, as I previously identified, consider not only the characteristics of the client, but also the characteristics and demands of the work, as well as the environment and context. So this really was what helped kind of conceptualize this research that I did, in fact, complete. There is evidence that supports OT's role in promoting return to work for other populations, such as those with mental health issues or musculoskeletal conditions, as I previously identified, as well as traumatic brain injury. However, there's not a lot of research that supports OT's role currently in provision of return to work services for stroke survivors. And what we do also recognize is that there is a gap in services to individuals after stroke. As I said previously, often stroke survivors of younger working age will not receive services or receive limited services. And research has also identified that there's a lack of healthcare provider knowledge with regards to interventions required, as well as resources that can facilitate and support return to work. And what the results of my survey and my study concluded, and I'm going to talk a little bit more about this, is that I did a national cross-sectional survey that in fact did reveal gaps in knowledge and practice patterns of occupational therapists. So really what my research questions were, I really wanted to know, are occupational therapy practitioners addressing return to work with working age stroke survivors, again, given that this is within our domain of practice? And then if so, what are occupational therapy practice patterns and competencies in the provision of return to work services for younger stroke survivors? And then what are the perceived factors that promote or may impede the provision of services? And then lastly, what is the perceptions of best practice with regards to providing return to work services for this population? So my study was actually an explanatory mixed method design. I did a cross-sectional web-based survey as phase 1 of this study. It was a national survey. And then following that, I did semi-structured telephone interviews with practitioners who had participated in the survey and were willing to participate in the interview and had provided me with their contact information. So I sent out a total of 4,000 invitations using an AOTA continuing education provider database, as well as a database from the American Occupational Therapy Association. I had 2 follow-ups at 4 and 8 weeks, so the survey was open for 12 weeks. And then after the survey was closed and the survey data was analyzed, I did interviews with 9 purposefully chosen practitioners who do have experience in providing return to work services for the target population, younger stroke survivors. So my survey tool was actually a researcher developed tool. It was based on the Occupational Therapy Practice Framework Domain and Process as a guide to organize the survey and capture relevant information within the domain and OT process, as well as extensive literature review. The survey was also piloted by experts who are occupational therapists and provide return to work services to younger stroke survivors prior to launching of the survey nationwide. So my survey was actually designed to capture the elements of the occupational therapy process, from the evaluation process to the intervention process. And when looking at evaluation, the initial step of an occupational therapy evaluation is to develop the client's occupational, and in this sense, the worker profile, to look at the activity demands associated with the job, as well as the environment and the influence of the environment. And then lastly, to look at the client factors, the body structures and functions, as well as performance skills, so the observed ability of clients to carry out the tasks associated with their job from a motor and a process or cognitive skill perspective. Additionally, I wanted to find out what types of interventions were being utilized, and the interventions were then categorized as either occupation-based, meaning that they used real life and or simulated work activities within natural context as best as possible, as well as interventions that specifically focused on the individual as far as body functions and structure. And then again, because this research was, this survey was developed based on literature review, strong emphasis of the importance of collaboration with the employer and the work site as far as facilitating return to work. So really wanted to look at, were occupational therapists engaging with the employer and the work site? And then lastly, looked at what types of advocacy interventions were occupational therapists participating in. So as far as the scale, I was looking at not only the frequency of use with regards to the components of both the evaluation and intervention process. So frequency from never or rarely used to occasionally used, frequently used, or regularly used. But then I was also looking at the perceptions of the practitioner's perceived skill as far as the components of the evaluation and intervention process, from being not skilled to all the way to being very skilled. So my data analysis, once I collected the survey data, it was descriptively analyzed and reported, and then I did additional statistical analysis as far as looking at practice variables and making comparisons between specific practice variables, focusing on practice setting, caseload, meaning those individuals that saw greater than 50% of stroke survivors on their caseload, and then whether or not they did indicate that they do address return to work or they do not address return to work with this population. The interviews that I did were telephone interviews. They were digitally recorded, transcribed verbatim, and then analyzed using a priori coding. Research has indicated that there are categories of facilitators and barriers that influence healthcare provider behavior, and therefore these two a priori codings were used to then categorize the remainder of the data found in the interviews. And so I ended up having a fairly low response rate, which I was disappointed in. As I said, I had a large sampling of 4,000. However, I had a response rate of 119, so a little lower than I was hoping for. And you'll see from the information here that the majority of practitioners were in outpatient settings, and then secondly in inpatient settings. And when you look at the years of experience, majority of respondents to the survey had greater than 10 years of experience. 47% of respondents indicated that they provided services to mostly stroke survivors, and of the stroke survivors on their caseload, 43% were of working age. 60% indicated that they do address return to work, whereas 40% indicated that they do not. So when you look at these diagrams, I'm going to try and explain, because I'm just kind of going to go through, as I said, the occupational therapy process as far as the evaluation process and the interventions. So the first step of the occupational therapy process is establishing, as I said, the occupational profile, or in this sense, the worker profile. And you'll see, and again, we're using that scale where 4 is regularly and 0 is rarely. And you'll see that occupational therapists do regularly gather information on the type of employment that an individual has participated in, whether they're a full-time or part-time status or on call. They also do look at other life roles and daily habits and routines. And then you'll start to see a trend where less attention is devoted to perceptions of readiness to return to work, the value and meaning of work, whether or not they have an insight into deficits and strengths that are related to their work performance, as well as goals related to work. So then looking at the analysis of the actual work demands and the environment, the primary methods of evaluation of obtaining this information was subjective information obtained from client interview and family interview. Less so were actual job descriptions looked at, or were job databases used to gather information about specific job requirements, and then standardized tests and more specifically worksite visits and employer interviews were rarely engaged in. So when you look actually at what are the occupational therapy, when you look at the demands that are looked at within this data collection, predominantly looking at what are the physical work demands, what are the cognitive work demands, and to a lesser extent communication, interpersonal work demands, and then to even a lesser extent focusing on what are the emotional and psychological demands associated with work. And again, when we look to the literature, there is evidence to support that emotional and psychological health and wellness and ability to cope is a strong predictor and facilitator of ability to go return to work. In looking at what type of information is gathered about the work environment, again, looking at physical environment is explored, looking at transportation needs and availability of transportation, but then less so, is there support from the employer? And what is the social environment and social support? And again, as I said earlier, when you look to the literature, both these factors, employer support and social environment, are strong predictors of ability to return to work. So this is a little bit of a busy slide, I recognize, but just again, looking at specifically evaluating client factors and performance skills. So those body structures and functions and skills of the person themselves. So the method of evaluation, again, strong reliance on client interview and family interview, looking at clinical observation, less so using standardized tests, and definitely less so doing actual evaluation or worksite observation. And as you can appreciate, being a clinical observation, we recognize the impact and importance of the environment and context. And so you really aren't getting an accurate indication of how an individual will actually perform in real work tasks in real work environments strictly by clinical observation. So again, when you look at the scale with 4 being regularly and 1 being rarely, we'll see that occupational therapists are regularly gathering information and assessing neuromuscular function, musculoskeletal functions, somatosensory functions, visual perception, as well as cognition, more so primary cognitive function, as opposed to executive cognitive function. And again, when we're discussing younger stroke survivors, particularly those with mild stroke, deficits in executive cognitive function are a significant barrier in the ability to resume life roles. And you'll also see then that there's less focus on the emotional and psychological function, as I had previously identified, which is a relevant area. Looking at performance skills, again, looking at physical skills and cognitive skills, you'll see that they are regularly assessed, and then less so social skills and mental stamina and endurance. So now I'm going to talk about the types of interventions that occupational therapy respondents to my survey indicate that they're engaging in. And the next few slides, you'll see I had mentioned that I was looking at both frequency of intervention, how frequently the interventions were being used, and then the perceived skill in the delivery of those specific interventions. And so the blue on the right for the frequency is regularly or frequently are these interventions provided, and then on the right side of the screen you'll see the perceived skill, and the blue corresponds to very skilled or skilled. And so it's not surprising, you pretty much see a comparable one-to-one relationship between the types and the frequency of interventions that are being utilized and implemented, and then the perceived skill with those particular interventions. And so a lot of perceived skill and therefore a lot of frequency of use of neuromuscular re-education, addressing again client factors and performance skills and retraining, a restorative approach. And then as you continue on down, you'll see as far as training in task modifications to enhance the work and compensatory and worksite modifications and use of real life work activities, these start to then become only occasionally and rarely used. And then you'll see then that there's a comparable perceived skill level to the use of those interventions. The asterisks on these slides indicate that those are what we're considering occupation-based interventions. So interventions, as I said, that incorporate either real life or simulated work-related activities and environments. So when we go to the next slide now, I had mentioned that I was asking about what types of interventions are occupational therapists utilizing that are employer focused, so focused on the employer or the work site. And you see quite a difference here. Again, the colors correspond to the same, where blue is frequently and regularly, as well as perceived skill is skilled or very skilled. So you'll see that there's a predominant red indicating for the most that occupational therapists are really not focusing interventions on the employer or the work site, rarely collaborating with the employer, rarely discussing reasonable accommodation or educating the employers on the effects of stroke, or consulting with return to work goals and recommendations. You see a little bit less of a one-to-one relationship of perceived skill. So you'll see that occupational therapists perceive that they do have skills in these areas as far as the ability to provide interventions that focus on the employer and work site. So then the question one would have is, if the perceived skill is there, what is impacting the frequency of actually using these interventions? And so this is where really wanting to find out what are the barriers. So then also I asked, was looking at how much advocacy interventions practitioners were engaging in. And again, we see a bit of a discrepancy between perceived skill and the actual frequency of use of advocacy-oriented interventions, predominantly looking at promotion of client self-advocacy in collaboration with others, some referrals to state and community services, but not really advocating for client accommodations or advocating for reimbursement at national and state levels. We do see that practitioners have a higher perceived skill with regards to collaboration, but again, less with actually advocating for worksite accommodations. So again, we're looking at this discrepancy between skill and actual frequency of use. So again, the question is, what is the barriers that are contributing to this? So when we looked at the barriers, some of it was gathered on the survey and the majority of it was gathered in the follow-up interviews. And one of the barriers identified was that clients that sustain a stroke have multiple needs, in that return to work and addressing work was perceived to have a lower priority. However, as I mentioned earlier, we recognize that stroke severity in younger working aged population tends to be more mild to moderate. And therefore, as far as the multiple needs of independence and ADLs and mobility may not be as much of a priority as returning to work. Also identified was a lack of knowledge of work-related regulations, services, resources, as well as reimbursement mechanisms, contributed to not providing return to work services, as well as a lack of expertise. So the studies that were previously done, and as I said, by Wolfbaum and Connor in 2009, where indicated that there was a lack of healthcare provider awareness and knowledge. The results of this study seem to support that as well. Additionally, system-related barriers seem to negatively impact the ability to address return to work, such as having limited visits and or reimbursement for services that focus on community integration and work, having a lack of time, which was compounded by productivity demands. Practitioners also strongly identified a medical healthcare model as being a barrier to provision of return to work services, in that community integration and return to work was not perceived as necessarily a medical necessity by the healthcare system and reimbursers and payer sources. And this was also discovered that there was some level of dissatisfaction with state vocational rehabilitation services, which ultimately contributed to a decreased referral to these services. Some practitioners had a good working relationship with their state vocational rehabilitation services, but that was fostered through networking and collaborating and creating systems and policies that allowed them to work well and collaborate, whereas others found that there was a lack of responsiveness, a long waiting time, and follow-up with clients led them to believe that the services were not specifically addressing their clients' needs. So then what was perceived as the facilitators of the ability to provide return to work services? So this should not be surprising if someone indicated that they had prior training and experience in work-related services. And particularly this was focused on individuals that may have worked in settings, industry settings, or work in industry settings that focused on work-related injuries or functional capacity evaluations, that they felt that they were able to take that prior training and experience and then just provide similar services when working in settings with stroke survivors. Additionally, practitioners that were mentored by experienced practitioners also found that their competencies and skills increased. And when we look at the system level, organizational administrative support was really important. One practitioner indicated that she had significant support from her organization to provide return to works, even though this was a cost to her productivity, but the organization was in support of providing necessary, meeting the needs of the societal needs of their local community, and then felt that it was a really important service to be providing. Also, the ability to provide longer treatment than is typically afforded in some of the traditional settings was an opportunity to really focus on return to work services, as well as funding beyond third-party payers. So instances where individuals were employed where payer sources were state funding, in one particular instance funded by the local university, as well as funding by private pay. And so this is just a quant looking a little bit as that statistical comparison. I was looking at practice variables earlier. This is by no means everything that I was looking at. However, in this instance, I was really just wanting to get a sense of knowledge of work-related laws, as well as knowledge of reimbursement mechanisms to be able to provide these services while still getting reimbursed. And again, the scale, as I said, is 4, is that they strongly agree that they have work-related knowledge, and 1 is they strongly disagree. So you'll see that the numbers here indicate that they disagree and strongly disagree that they have this knowledge. However, there is some significant difference between whether or not someone does provide services or not, whether if they're in an outpatient setting, tend to have a little bit more understanding of it, as well as if they have a caseload of greater than 50% of working aged stroke survivors. So then, as I said, the last question of my research I really wanted to know is what were the perceptions of occupational therapy practitioners with regards to best practice? And we identified that best practice was the result of addressing return to work in the early stages following stroke. And this is definitely supported by the research and the literature, where you'll see some references stating that we should be focusing on return to work in as early as 8 weeks after stroke, whether or not whatever setting that they're in, and then also advocating that for relevant services and referring all stroke survivors for comprehensive occupational therapy services. As I mentioned earlier, there is a tendency for individuals with milder stroke to be discharged with little to no services and then little to no follow-up. And so often, as I said, we don't really have a true sense of someone's ability to resume normal life roles and participate at the community level again until they actually engage in real life activities and roles. So we really need to make sure that we are following up, as well as making sure we are referring all clients for services. We need to make sure that we're using ecologically valid evaluations, which again means that we're looking at evaluations that really provide us with real life information as to whether or not someone can engage in occupation, so that the results are applicable to their work task and work environment. We want to make sure that we're providing occupation-based services, again, not necessarily just focusing on the individual and restoration of skills, but focusing also on what are the task demands and activity demands of the work, as well as what is the context and work environment as to whether or not that supports or creates barriers to the ability to return to work. Importantly, practitioners identified the need to address emotional regulation and coping skills. However, when you go back and look at the results of the survey, did indicate that these are the area that is not addressed as much. And so this is really an important area for all disciplines to be addressing when we are working with younger stroke survivors. And then really looking at executive function and not attempting to necessarily restore cognitive skills, but looking more at training in compensatory strategies and assistive technology use that will allow them to return to prior life roles. And last but not least, as not surprising, I identified earlier, was to really make sure that we're engaging with the employer and focusing interventions on the employer. And because of a lack of competencies and skills, if we're going to be able to provide these services effectively, we definitely need to make sure that we're developing enhanced competencies in these services. So then the question is, what is perceived as needed competencies to be able to provide these services? One, we need to be able to understand the laws related to work and the regulations and the resources that are out there that do support return to work. We need to be able to have an understanding of a variety of jobs and job demands so that we can accurately analyze and decide whether or not there's a match between the client's abilities, and if not, the ability to provide accommodations or compensatory techniques, and then ways to actually research job demands. There's ONET is a website by the U.S. Department of Labor that provides job descriptions and expectations and skills, necessary skills and knowledge for hundreds of jobs. We also then need to be able to perform a job analysis, and that includes not only looking at the individual, but also looking at the physical and social work environment, as well as the cognitive environment. We need to be able to engage in multidisciplinary and multi-service collaboration, though this is traditionally done in inpatient settings or skilled nursing settings where practitioners are used to interdisciplinary or multidisciplinary collaboration. We're not doing a really good job at the community level of integrating and collaborating with different disciplines. The ability to collaborate with the client's employer and make connections with the client's employer, and then developing critical reasoning skills as far as understanding whether there is viability of the employer and the return to work readiness of the younger stroke survivor. Lastly, we need to develop skills in advocating for needed services and reimbursement of these services. And so practice implications, kind of in summary, really looking that we need to provide a top-down approach. We need to not focus on the person at the bottom, but we need to be able to focus on the occupation, the job, the work, and then fostering interventions and services that will enable a person to return to work. We also have implications for then entry-level education and professional development needs. The results of this survey indicated that practitioners perceived a lack of expertise and lack of knowledge. So, and that those that did have experience and knowledge were more readily able to provide these services. We also need to enhance our advocacy efforts and then also enhance skills and the ability to advocate, since again, this was an area where there was perceived level of low skills in this area. And then considering alternate models of service delivery from those that we're traditionally doing. And so there's opportunities for further research, looking at the effectiveness of occupation-focused interventions, looking at the effectiveness and ability to provide alternate models of service delivery, and what is the impact of education and professional development activities on the ability to provide these services. So I do recognize that there are limitations in this study. As I said earlier, there was a low response rate. So the ability to generalize, in addition to most respondents being primarily in outpatient settings. My sense is that the invitation to participate in the survey did include that we were looking at return to work services for persons with strokes, so maybe many practitioners opted out. The survey was a little lengthy, which may have been a limitation, and I did not get any information on actual return to work outcomes based on the interventions being provided. However, I do think that this was a relevant study, as it was one of the first to explore what occupational therapy practitioners do and what they perceive they can do in order to address return to work after stroke. And I believe that it has significant implications, given, as I said, that work is within the domain and skills and entry-level education abilities of occupational therapists to address. So this is the my actual survey or my study that was published recently. If you're interested in getting more information on it, it can be found in Occupational Therapy and Healthcare. I did also want to talk then, as I said, that I think though there are implications for occupational therapists, the results of this study also lead to strong implications for interdisciplinary practice as well, in the sense that all disciplines we should be addressing early assessment and intervention, focusing on return to work and not waiting until individuals either fall through the gaps or we lose follow-up contact. Also looking at alternative models of interdisciplinary service delivery where we have interdisciplinary teams, perhaps led by a case manager that coordinates all activities that focus on the return of work of the client. And there is research that supports that these alternate models have been successful, particularly with individuals with traumatic brain injury. Definitely emphasis on the need for interdisciplinary collaboration and communication. comprehensive screenings and follow-up. And I highlighted follow-up in the sense that we need to make sure we're following up with survivors, not only after they're discharged from our facilities or from our hospitals, but also after they return to work, if they do in fact return to work. As I said earlier, often the limitations and persistent stroke symptoms that negatively impact work don't necessarily surface until the individual has returned, and we often aren't providing the necessary supports and services to the individual to foster successful return. Definitely make sure that we are referring clients to appropriate services to address the multiple needs and predictors of return to work, and make sure that we are advocating for changes, hopefully, but also for provision and reimbursement of services that will allow us to actually address work and community integration. And so there's also implications for interdisciplinary research to look at the impact of alternate models of care and service and the cost effectiveness of these alternate models of care. So this is an article recently published by the Health and Wellness Task Force from the Stroke ISIG of ACRM, which I happen to be, I'm happy to have been a member and am a member of, that provides further information on not only interdisciplinary approaches to facilitate return to work, but also to foster services that will facilitate return to driving, which is also a significant component of the ability to return to work, is transportation. And so these are my references. And then I did just want to open it up for any questions or comments that anyone might have with regards to this. And again, I thank you for your time and your attention.
Thank you, Dr. Scott, for that very relevant work that you've done. I commend you personally for going where no one has gone before, so that's very brave of you. I cannot believe that this is the first study for return to work practice among occupational therapists, so thank you for that. There's a comment on the chat box from Mark Kovic, our Stroke ISIG chair, and I'm just going to read off of it a bit just to get the discussion going. And thank you very much for your presentation. It's a very necessary discussion. And some of us were at ACRM last week, and he personally attended an implementation science presentation related to stroke. And they discussed having exemplars within hospitals. And the exemplars within hospitals might be advocates for changing practice. And what are your thoughts on this matter? Like, what do you think? Do you have any insights related to beyond occupational therapy that we can do so that we can have exemplars for stroke practice within our own settings?
Right. I strongly support that. And my sense is, and again, kind of just looking at the results of this, my study, is that we tend to operate in silos, is my perception, whereas we're not necessarily collaborating and working together, and we're not necessarily focusing on the needs of the individual. And I think a lot of that is perhaps the perception that someone else is in fact doing it, when in actuality no one is doing it.
Right.
So I think the perception that there's no one taking the lead. So I think that if there was an exemplar and somebody that was actually taking the lead, that there could be more of a cohesiveness and maybe an intercollaboration. I mean, that kind of actually goes along with what I was saying previously about maybe these alternate models of care where you actually have someone within facilities that is responsible for looking at the community reintegration needs of stroke survivors, and that will take the lead on these topics, because again, they're not being addressed.
I agree with your answer there, and I was thinking to myself as well, in the practice of occupational therapy, just because I'm also an occupational therapist by background, we address things like return to school when it comes to the pediatric population. But you are so right in saying that there's such a gap once we get to the adults who have had their work interrupted. So thank you for bringing up those points.
And I think the other thing that, again, this is just my own personal kind of observations and perceptions, but, traditionally we have provided services, and there is emphasis of services for younger populations, such as those that spinal cord injury, because that tends to be a younger population. I think also with traumatic brain injury, again, tending to be a younger population. However, and I don't know whether there's still this misconception, and it's been a long time, where stroke, it was still deemed, something that happened to older adults and not necessarily something that was occurring in younger adults. But as we've seen from the statistics, the numbers are continuing to rise in younger population. And so we really need to, rise to the occasion and rise to the challenge and make sure that we're addressing those needs with this population as well.
Do we have any other questions? Okay. Well, thank you so much, Dr. Scott, and we're looking forward to more collaborations with you and your work on the Health and Wellness Task Force. And with that, thank you everyone for participating, and we will send you details regarding the next virtual happy hour. Good evening.
Great. Thank you so much, Cecile. I appreciate this, and thank you, everyone. It's been a pleasure.
Bye.
Bye-bye.